Good afternoon and welcome to our session for updates to the Medicare Parenteral and Enteral Nutrition policies 2 years later, the impact on providers and patients. So today we have a few announcements before we get started. You have a few opportunities left this afternoon to delve into some perspectives in the 30-30-30 session still, the side chat, or roundtable sessions following this, so check those out. Many great topics to choose from, and catch one of the ones you missed, sponsored by Citus Health. Tonight's signature networking event will be held at the Punch Bowl Social, a giant fun-filled factory with 3 floors of entertainment options, from bowling and ping pong to all the karaoke people get out there with us, and a giant wall of Scrabble. I think that's where I'm going to hang out. There will be scratch-to-craft food options and drinks across 4 bars with plenty of ways to network. You still can complete your CEs and have 45 days to do so, and you can even visit the meetings that you didn't get to attend. You can go back and review those and get your hours later, and that's a CE on demand for a year after this. The evaluation code, as we have seen, comes up at the end of the session on the last slide. And if you don't need CE, there will be a tablet outside that you can respond on, or you can hit your phone on the QR code and download a survey. Of course, during the Q&A portion of this presentation, please go to the microphone so that the people that are viewing it later are able to enjoy, and we may want to walk the microphones around since we're having our more of a fireside chat type format here. Now I'd like to introduce our speakers for this session. We have Penny Allen, the Vice President of Optum Infusion Pharmacy, and she'll be presenting alongside Jacqueline Oberman, the Nutrition Clinical Program Manager, both with Optum Infusion. And you can read more about the accolades and honors of our esteemed speakers in your conference program. Welcome, and thank you for sharing your knowledge.
Oh, we need the clicker. The clicker is essential. Yeah, we figured we're going to mix it up since it's the end of the conference, so we're not going to get up on the podium so that I don't fall down or anything, because I'm noted to be a klutz. Many on my team will know. So thank you for coming. Was anybody in the session yesterday morning? Just a heads up that a lot of the information is going to be the same, except we're not going to go into the sales aspect about it, about how to leverage this and use it from a sales perspective to grow your business. So this will be just more of a deeper dive into the actual Medicare, the policies, and then this time we'll allow for some questions and concerns. I've already heard a couple of questions, and yesterday we really didn't get to that. So hopefully you won't be bored if you were here yesterday too. Whoops. Let me go back. So what we're going to do is talk about the changes to the Parenteral and Enteral Nutrition LCDs, describe the impact on access to care, HPN care primarily. We'll touch on enteral a little bit too, but for Medicare beneficiaries, since the change to the policy in 2021, we'll talk about 2 to 3 documentation changes for providers. There's actually more than 2 or 3, but in the objectives, you have to have measurable objectives. Outline risk issues for providers when dealing with CMS and the DME Max. We kind of buzzed through that really fast yesterday, but we'll spend a little bit more time on that today, because a couple people commented after that they thought it was great that we talked about it, because we don't talk about it as much as we probably should. And then we'll verbalize what remaining NHIA advocacy initiatives are still out there pertaining to home infusion access. And you probably heard a lot about that. Bill, I think, is he here? Yep, he's in the back. I know we reviewed some of this, like even Christina reviewed some advocacy bills and things this morning in her health equity talk, MNT, Medical Nutrition Equity Act, et cetera, et cetera. So other advocacy issues that pertain to our patients, especially in the nutritional realm. So I'm going to give you a little bit of background history, and again, apologize if this is duplicate, but those of you that have been in home infusion for a while, the coverage criteria was established as a national coverage determination in 1984. I'd venture to bet some of you weren't even born yet, but it never changed after that. So it was literally 36 years. We lived with the same premise regarding Medicare coverage of parenteral and enteral nutrition. And we all know clinical paradigms change, practice patterns change, the types of patients. It's not that it's changed a whole lot, the type of people that need PN, but certainly when I started in home care, the majority of the referrals we got back then were all long-term patients with short gut, because biologics weren't even invented yet when I started in home infusion. So there was no such thing. You just went to the OR and had resection after resection after resection until a lot of our long-term patients had a foot left, 2 feet left, and they were lifelong PN patients. So nothing was updated until 2021. So PEN is the acronym used by CMS. Still today, was put under the prosthetic device benefit of the DME POS benefit. And the mentality was, well, the tube or the pump serves as a prosthesis for an organ or a function of an organ. Something's working, it's not going to get fixed anytime soon. So this is a lot of the big issue, and we've been fighting for a home infusion, a legitimate real home infusion benefit for Medicare beneficiaries. That's what we're fighting against. You know, with the care that we provide, the clinical services, the monitoring, what you do as a pharmacist, a nurse, a dietitian, a tech, everybody involved in the process, none of that is recognized by Medicare. Everything is about the pump or that prosthetic device mentality. Like say you had kidney failure and you were getting dialysis, that dialyzer is taking the place of the kidney. For parenteral and enteral, that pump, is taking the place of your small intestine. The coverage criteria has always required a permanent impairment, but we all know, those of you who deal with PN today, not everybody needs PN for a long, long time. There are patients with cancer that have been excluded from access to care because maybe they only needed it to finish their chemo regimen and they had severe mucositis or something like that. Maybe they had a bariatric surgery and they had a complication after it. It might be more temporary, 6 weeks, 8 weeks. It wasn't always lifelong indications. So back in the day under the old law until 2021, every major company did a poster, an abstract, or whatever, and the numbers were 10 to 12, 10 to 15% of the time people met criteria, which meant an awfully large chunk of patients who had valid Medicare benefits didn't have access to home PN. What was that? I didn't want to click that. Come on. All right. See, maybe I have to point it at something.
Somehow it's pulling up a menu.
All right, sorry about that. Thought I was good with the clicker.
It's not working up here either.
Oh,
Let me try, very
that went away. Okay, let me try. There we go. All right. So prosthetic device, not to bore you with the language, but I think if you're not as fluent, not as familiar, this is a weird, what's the right word I'm looking for? Comparison. It's a weird way to look at, TPN and enteral as a prosthetic device. This language comes straight from the Medicare manual, and I think it helps, it may help you when you're trying to explain this to a customer. A lot of what we talked about yesterday was like, how do you handle the irate customer, the frustrated doctor who doesn't understand this policy because it sounds idiotic that, TPN or enteral is like a prosthesis. So that language is where we still live today. Their comparison is like artificial limbs, cardiac pacemakers, but it does help to understand that long and indefinite duration piece of it, because it's really meaning like we don't pay for anything temporary. So it's kind of like a prosthesis. When we get to the new policy, that's caused a lot of confusion out there because it used to say ordinarily at least 3 months. In the LCD, in the policy article, it doesn't say that anymore. It says long and indefinite duration. And I've talked to a couple people at the round tables last night, and they're, who dial into, no offense to Noridian and CGS, the DME Max, but when you say, well, what does that mean? And they just repeat it back. It means long and indefinite duration. So that's created a gray area, I think, for a lot of providers since the law changed, because what is your definition of long and indefinite? I don't know. They don't tell you. So default to what it always was. That's probably the most conservative route. At NHIA, we've heard from providers that report a lot of denials a lot of take-backs, because after the law passed, they thought that was like a free-for-all, like, okay, I'm going to start taking 6 weeks or 8 weeks or whatever, and they were getting denied claims. So in the Medicare manual, there are still some LCDs that are unrelated to what we do, but because they're under prosthetic device, that language of 3 months still lives in other policies. So we say default to that just to be safe. Last fall, if you haven't followed the infusion magazines, like the last 2 falls have been a nutrition issue. There's a lot of good information. If you have a client, a customer, a doctor, and they say, this doesn't make any sense. Why is your company being so difficult? You know, I don't get this. This is stupid. Or if you just want to read up and have a refresher for your internal teams, your Medicare teams, your billing teams, there's a good overall review of living with the new law as it is. It gives a little bit of the history, talks about, you know, the access and how it's somewhat better than what it used to be, but it's a good overall review article. So we'll talk about resources again at the end, but there's also some good general checklists in there. If your company doesn't have a new checklist, you need to throw away all the old stuff you have. Someone asked us yesterday about, what about that flow chart? You know, that one that's been around since like 1982. And I was like, oh no, the flow chart doesn't exist anymore. You need to take that and throw it away. Clean out your drawers. We got that checklist from a teaching hospital recently in California that we're still using it, and we're like, oh no, the law changed, you don't need that anymore. So people, you know, everybody's busy, we're all doing our own thing. So there are some simplified ones that you can create your own, slap your logo on it if you want, but I always find that really helps customers, because you're saying, I'm not asking you these crazy questions to be a pain in the neck, but here's a nice easy way so you can see what the policy is, what we need from you, to make life easier. So this sums it up briefly. Jacqueline will take over.
Thanks, Penny. I'm not going to tell you to clean out your drawers because I'm not from a part of the country that says that word. Maybe giggle. Yeah, but raise your hand if you have read through the PN LCD that came out in September of 21. Okay, so quite a few of you. That's really great to see. One of the things that Penny really alluded to is that in the Infusion magazine there is an article with really good checklists. I see a few of the authors here in the room, so thanks to you guys for really laying out that information in such a nice, organized way that's easy to use. The LCD obviously has all of that information in it, but it doesn't have a really nice checklist that, you know, concisely or in a bullet point kind of format tells you exactly what's needed for home parenteral nutrition coverage. You really have to read through everything in detail, and I know for a lot of people you can end up getting lost in that. And then the LCD also refers to the policy article, and there's just so much information. It can be really hard to navigate that and figure out exactly what's needed for coverage criteria. So I'll hit some of the highlights for the clinical portion of that coverage criteria here on this slide. The very first thing that we're really looking for is a permanent impairment of the GI tract. So what's wrong with the GI tract? And that's not necessarily new information. The old LCD, of course, required something to be wrong with the GI tract. That it was just much more specific. But we're definitely still looking for a permanent impairment or a functional impairment of the GI tract. And we often see clinical documentation for Medicare beneficiaries who need home parenteral nutrition, and their diagnosis is listed as malnutrition or something that is nutrition related, but doesn't necessarily tell us exactly why the patient needs parenteral nutrition. So we can have people with malnutrition who still have a functioning GI tract. They don't necessarily need home parenteral nutrition. So malnutrition doesn't necessarily tell us exactly what's wrong with the GI tract or specifically why the patient needs parenteral nutrition. So when we're talking about a permanent impairment or that diagnosis, those two key components go together: what's wrong with the GI tract and why specifically does that patient need parenteral nutrition. Something that's really new, and I'm going to hit on this again throughout the presentation, but something that's new in the latest LCD is like the central statement or the treating practitioner needs to document that enteral nutrition has been considered and ruled out as an option because it's just not feasible for this patient, or it may not be safe for this patient, or it's been tried and it was ineffective, or it's tried and not tolerated. So again, something that's really new to us for clinical criteria or coverage is that enteral statement. And then we also have how long does the patient need parenteral nutrition? That's something that's always been there in the clinical coverage criteria and is still here with us. So how long does that patient need parenteral nutrition? And the current LCD tells us that the treating practitioner needs to document that the patient needs parenteral nutrition for a long and indefinite duration. And we've been hearing from a lot of people that that's really gray area, and I'll also personally admit I feel like that's kind of gray area. How long is a long and indefinite duration? And as Penny said, there are still other policies out there that specify that 90 days equals permanency in Medicare's eyes. So while the newest parenteral nutrition LCD doesn't specify that 90-day criteria that we were used to with the old parenteral nutrition coverage. It's still kind of a safe bet to say, yeah, Medicare is probably looking for something around 90 days or greater, but the current LCD uses language of a long and indefinite duration. And then the other piece that we don't have on this slide, because it really gets kind of more into the nitty-gritty details, is the parenteral nutrition prescription. So Medicare does have some criteria for exactly what that parenteral nutrition prescription needs to provide. So there's a calorie specification, a protein specification, a lipid specification, and again, we just don't have that on this slide because that's like more in the nitty-gritty details, but I just don't want that to be completely left out of the conversation. So what the new criteria is looking for is a medical chart that really substantiates the criteria that's here on this slide. That permanent impairment of the GI tract, the enteral statement, was enteral nutrition considered and ruled out, or was it not tolerated? And then that piece of the long and indefinite duration. And when we say that needs to be substantiated throughout the medical chart, we're talking about progress notes or clinic notes, the history and physical note. We got a lot of questions at our roundtable last night about having these pieces of information written on the PN prescription. And Medicare just doesn't consider the PN prescription to be part of the medical chart, the legal medical chart. So the criteria listed on the slide here does need to be included in those progress notes or clinic notes written by the treating practitioner and not on the parenteral nutrition prescription or that PN order. Maybe if you turn around 3 times and then click it.
See, we thought it was a good idea to make it a little casual, and maybe
Well,
not.
it seems to be working sometimes and then not other times.
Okay. It just keeps getting stuck with, oh, you know what?
Well, it's stuck on the
It's
laptop, too.
touching multiple buttons, yeah.
Yeah, I just did it. Yeah, I had to use the drop-down box, so, okay, we'll stay up here, just in case.
Okay. So now I'll talk in a little more detail about what has changed, what hasn't changed. We hit on several of these things on the last slide. But as far as things that have changed in the newest PN LCD, there's no longer a need for multiple objective tests. So with the old clinical coverage criteria, Medicare kind of said, and these are my words, sure, the patient has that diagnosis, now prove it with a test. And they required things like a fecal fat study, a 72-hour fecal fat study, if we were looking for malabsorption, or a CT scan proving that the patient had a complete mechanical small bowel obstruction. So they're no longer requiring, or the new LCD is no longer requiring evidence by tests. However, of course, that medical chart does still have to substantiate everything that the treating practitioner is writing for. Another thing that's changed, we talk about that enteral statement, but of course that's now required. That enteral nutrition was considered and ruled out or tried and ineffective or exacerbated that GI dysfunction. So that enteral statement is a completely new piece, and that's really great. I know we're going to talk about oncology diagnosis here in a couple of minutes, but in the past, we really saw a lot of patients with cancer who needed home parenteral nutrition, and specifically really with like small bowel obstructions, maybe a partial small bowel obstruction. And the old LCD required that you do a tube feeding trial. And so many of those patients couldn't tolerate it or weren't appropriate for it. It wasn't a safe thing to try in that patient. And so unfortunately, they just didn't meet coverage criteria, so they didn't get the parenteral nutrition that they actually needed. And so now, as long as the treating practitioner writes that that enteral nutrition was considered or tried and found ineffective, then that's our enteral statement. The protein range, it was increased to 0.8 to 2 grams of protein per kilogram per day. So that's one of those kind of nitty-gritty, detailed PN order details that I was talking about. The PN lipid dosing is also now consistent with product-specific dosing guidelines. And so depending on which lipid product is being prescribed for that patient, the Medicare range is now just consistent with the product-specific dosing guidelines. And actually what the LCD specifies is that you can't go over that lipid range that's in the product-specific dosing guidelines. However, if the lipid dose is under that range, then that's A-okay. Or if the patient can't tolerate lipids or isn't on lipids for some reason, that's okay. But if the dosing is over what that product-specific guideline says, then it just needs to be justified by the treating practitioner in the medical record. And then the treating practitioner needs to have seen the patient or assessed the patient within 30 days of starting parenteral nutrition. So that's another new thing that's really specified in the LCD. However, the LCD does have an allowance for if the treating practitioner didn't actually see and assess that patient within 30 days of starting parenteral nutrition, that needs to be justified in the medical chart. So we've actually run into this, or we've seen a couple of cases of this recently, where a patient was either evaluated, maybe in an outpatient setting, just over 30 days before parenteral nutrition was really warranted and then prescribed for that patient. And that can just be justified, again, by the treating practitioner in the medical chart. But if that patient hasn't been assessed in person by a treating practitioner or prescriber in over a year, then this may not really be, home parenteral nutrition may not be a safe situation for that patient anyways. But they do need to be evaluated within 30 days, or that needs to be documented or justified in the medical chart. So what hasn't changed? Parenteral nutrition is still billed under the Part B prosthetic device benefit. That's something that Penny talked about just a few minutes ago. And again, Medicare is really seeing that infusion pump as the prosthetic device. And so it does still fall under Part B and prosthetic device benefit. And then that permanence, or that permanent need for parenteral nutrition is still a requirement, but the language has changed. So as I said a few minutes ago, the old PN LCD stated that a patient needs to be expected to need that parenteral nutrition for 90 days or greater. And now what Medicare is looking for is the patient to be expected to need parenteral nutrition for a long and indefinite duration. And just keep in mind that if a treating practitioner does specify, this patient needs parenteral nutrition for 90 days or greater, that's still okay. They don't have to use the exact words of long and indefinite duration, although long and indefinite duration also is an acceptable option. The parenteral nutrition indication or the diagnosis does need to be related to a permanent small bowel impairment or this functional impairment of the GI tract. And this kind of goes back to that example I mentioned a few minutes ago of like malnutrition being the primary diagnosis for parenteral nutrition. Well, someone can be malnourished and appropriate for enteral nutrition, or someone can be malnourished and appropriate for PO nutritional supplements. So why do they really need parenteral nutrition? Why is parenteral nutrition the only option for that patient? And so that needs to be supported by the medical record. And again, we're talking about clinic notes, progress notes, a history and physical note, something in the medical chart. The old LCD did have a calorie specification for that parenteral nutrition prescription of 20 to 35 calories per kilogram per day, and that still stands. And if a patient needs more calories than that in their parenteral nutrition or a lower amount, that's okay, but it does need to be justified in the medical record by the treating practitioner. However, if that parenteral nutrition prescription falls within this range, then we don't need any additional justification by the prescriber. And then all documentation is required prior to start of care. And that's something that came up several times again at the roundtable last night, is, really what is Medicare, exactly looking for, what has to be signed or documented or pulled together before the patient actually starts their home parenteral nutrition. And all of the clinical coverage criteria does need to be documented, and then really should be on record with the home infusion company prior to start of care, or at least prior to sending claims to Medicare. And so that's that other kind of gray area. We do often see patients who have, let's say, commercial insurance when they start parenteral home PN, and then later on they switch over to having Medicare as their insurance, and that's okay. They had their start of care a long time ago, right? So you didn't have to have all of the Medicare coverage documentation on file when they started home PN, 2 years ago with their commercial insurance, but it's really prior to sending any claims to Medicare.
You know what, I'll give a little bit of color for background. When Bill and I met with the DME Max in, it was July 2020, in the middle of COVID, when you look at this slide and you say, well, it doesn't look like a lot's really that different compared to what the old policy was. When we went in there, we were asking for change to the policy. We pulled together a team of clinical experts, Medicare experts really, and we pulled the most current evidence-based medicine, research articles, literature from Aspen and so forth, because we wanted them to understand that all of us as organizations, Aspen, NHIA, OLI, we had been lobbying them for a very, very long time to even just, let's throw out the long and indefinite duration or 90 days. Can we throw out fecal fat? Can we throw out that INO? Just pieces, because, no one uses albumin anymore, let's say, to document malnutrition. And it was a great meeting. We didn't expect it to go as good as it did, as I described yesterday. They kept asking for more and more literature, and we think back and go, okay, the premise of the policy is that old NCD that I talked about, 1984, where it's still, you need to have a permanent impairment. There's got to be a malabsorptive or motility issue that's stopping the absorption of nutrients in the GI tract. We didn't expect them later that fall to just completely throw out the old policies. So keep in mind, we had about a year of limbo between November 2020, which is when they formally threw it all out the window, and we had to default to that old NCD, but not have situation A, B, C, D, E. All of that went away in November 2020. And then we had to wait to be able to provide comment and go back and wait for them to generate a new LCD. So by no means is the newest LCD from 2021 what we asked for. And I want to make that clear. That really wasn't what we asked for, but it's what they came back with, and we felt like we made some gains. We got some gains, and some of that was for us as providers to reduce the administrative burden. That's the way they call it, to reduce the amount of paperwork we need to do. So when we said, hey, people are using more than 1.5 grams of protein, can we go up to 2? That was a gimme. They let us have that so that you don't have to go back to your doctor and go, doctor, this patient's getting 1.8 grams per kilo. Can you write a note explaining why? Same thing with the lipid. In the old days, you were capped at 1,500 grams per month. And we gave the analogy to them, that's only 50 grams of fat a day. All right, when we dose fat for patients, we're usually dosing at least one gram per kilo. That's a 50 kilogram person. Almost no one is a 50 kilogram person unless they're an underweight TPN patient. So every single time, we're gonna have to go back to the doctor and say, hey, doctor, can you write a note explaining why, blah, 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 because then you're at risk of an audit and a take back. So they gave us that one. So we felt like, we got rid of a lot of the really troublesome things that used to trip us up and make it really, really difficult to qualify. They came back like, we're still in prosthetic device, it's still permanent impairment, definitely no short-term, temporary types of impairments, but we scored some points. So when we talk about that, we'll show what our experience has been. But I wanted to clarify, you look at it and go, So yeah, something's changed, but not a lot has changed. So again, keep that in mind, but it's, as Jacqueline said on the previous slide, it is all about the medical record. Don't think for a moment that you don't need any tests anymore, or that you don't need studies. The chart has to make sense. The whole story has to make sense. And a lot of times now, yesterday I mentioned electronic medical records, I don't know. It's making people not document as well as they used to in the old days. Maybe I'm just biased, but everybody's cutting and pasting the same story over and over and over again. And there are charts that we read that we just go, I don't even know why this patient's on PN. You need to give me the reason. Like as Jacqueline said, we had a whole discussion about ICD-10s and using the right codes, and companies complaining to NHIA that I'm getting, denials or whatever. Malnutrition can't be the ICD-10 code for PN. Patient may have malnutrition, but that's a secondary diagnosis. So think really carefully, even from the moment you get the referral, the information you're loading, that you've got the correct codes there, that it's that unspecified malabsorption or whatever, but you have to still follow the old rules to a degree in terms of the foundation of the policy hasn't changed. Some things about it are easier, but a lot of it's not perfect. So I just want to put that caveat out there. All right, so I was going to do EN. Yes, thank you for the reminder. At the same time, because Medicare puts PN and EN, they're two totally distinctly separate LCDs and policy articles, two totally different therapies. Really, it's all nutrition support, but that went, for review at the same time. Not a lot has changed with enteral under Medicare. The biggest thing that people commented on and wanted changed, it's almost like step therapy. If you've done any advocacy with that, meaning step therapy is like you're on this one drug, you know what, you have to try this drug first to make sure it doesn't work. And then can you only move to the next one? Well, it was like that with enteral formula. You had to try the basic intact protein, regular old osmolite, Gevity, or whatever first. But what if you had a patient who had a malabsorptive condition and could still get a tube feeding? You'd probably make them sick if you forced them to do that. So everybody that provided comment, the enteral companies, the home infusion companies, said, can we please change that so that if the doctor writes a note specifying that, you know what, we cannot try that intact protein formula, that basic B code with this patient because of X, Y, Z. Now you don't have to force the patient to do a trial of that. That really, truly is probably the only major thing that changed with the enteral policies. The other thing that changed this January is the DIFs went away, the DME information forms. Gone. So that's a change too. And if you want a new clean copy of the policy articles and LCDs, they've been updated as of January 1 to get rid of all that DIF language for PN and EN. But that's basically it. The premise of the enteral nutrition policy is the same. It's under prosthetic device. Something's broken up here. This is like your prosthesis thing. So the tube is acting as the prosthesis. The patient has a problem getting food from the mouth down to the GI tract where it can be broken down and absorbed. That has not changed. And when we look at the indications that are covered, again, no short term, no temporary things. No, this patient needs a tube feeding for 6 weeks. So we're just going to use an NG or an NJ, that's not going to be covered. It's the same long and indefinite duration. So the indications that you're going to see are the same as it ever was for Medicare home enteral. It's going to be neurological conditions like Lou Gehrig's, ALS, Parkinson's, severe dysphagia due to stroke, all those types of things. So B codes are the same. There was a lot of discussion at the time when we went in front of comment that we need to overhaul that whole B code thing and, the 100 calories per unit and all of that. I think that's a task for another lifetime, honestly. I don't know how the heck we'll get that all wrapped up unless the whole system changes. But I agree. Could it be a lot better? Absolutely. But we didn't get a lot, on the enteral side. So let me go to the next one. All right, so what has changed, like I said, you don't need I think this was urban legend, because this was never in the old LCD or policy article. People would say, you need a swallow study, you need it in, and I'm like, I've never seen that language. If you read the policy article in the LCD, it never said that. but it just became this thing that grew and lived over the years, I think. It's not there. It doesn't say that. So again, like everything else, the medical record has to support the story. So that swallow study, if it's there, awesome. It's like the fecal fat and PN. If it's there today, awesome. That supports your story that the patient is, severely malabsorbing or whatever. Whatever you've got for clinical evidence, you still need that. You can't just write a beautiful little paragraph, the day of discharge, and it doesn't jive at all with the rest of the chart. That's when we talk about the fraud and abuse at the end and your potential for getting in trouble with the federal government. The whole thing's got to match up. As providers, I think we're left holding the bag sometimes with people's desperation to get people out of the hospital, that on the day of discharge, the whole story changes a little bit. Things that were previously in the chart miraculously are gone today. That line was taken out. Or there was a 3-week estimated length of need written a couple times, and all of a sudden now it's 4 months or 3 months. So we've got to be really careful about that as an industry, because if you get audited or whatever, if they dug down deep, that could be construed as fraudulent. So we'll talk more about that after. What hasn't changed with enteral, kind of the same as I said about TPN. It's still billed under the Part B prosthetic device. Permanence is still required. Medical necessity for a pump, that has not changed. There's 4 or 5 reasons. You can't use a pump unless you clinically document that there's a reason. There's blood sugar issues, severe diarrhea, whatever. You still need that same language in there, documented by the treating practitioner. And all information obviously is needed before the start of care, for your protection as a company, otherwise you can't bill. I'll just talk a few seconds on audits for those of you who probably aren't, unless you're billers. I know there's some billing experts in here involved with the audit process. I can't recall which year recovery audit contractors, the RAC and all that came into play. It hasn't been that long, maybe 10 years or so. That's when we truly saw an escalation of audits in the industry. And think about it, I don't know if you know, recovery audit contractors get a percentage of the take that they take back. I joked when I first joined my company, and it wasn't under the Optum name back then, and I said, if you guys ever whack me, I'm gonna go work as a recovery audit contractor. Because I know all the places, all the times when things are missing in terms of documentation. But I digress. Maybe that'll be my retirement job. But there's lots of different, there's post-payment, prepayment, cert audits, RAC audits, all kinds of audits. So when people say, well, maybe we won't get audited, I would tell you, you need to think like you're gonna get audited on every claim. When you get your documentation, instead of winging it and saying, well, I don't have this, but when I first started with this company, the first month I was there, they came and dumped 12 big charts on my desk and said, hey, we've been denied on all of these, can you look at them? Read them all, I said, sorry. There's no length of need written in the medical record for any one of them. You're going to give all the money back. And they're like, what? So it's not intentional. People don't always know what the rules are. We still get that. Someone asked last night, what about if, she said, I'm fighting, my billing people are fighting against my salespeople about whatever, about letterhead, writing clinical documentation on letterhead. And I said, nope. Sorry, it says very clearly in the Medicare policy, substantiated in the medical record by the best judgment of the treating practitioner. Medical record. No prescription pads, SWOs, letterhead, whatever. So there's so much minutia. It's no one's fault. This is a lot. Unless you deal with it all the time and you've been dealing with it for 30 years and you've gone to federal court and you understand that whole crazy audit process, and it's different today than it used to be years ago. I loved it when we went to federal court. That was the best. We always won. We always won. You had a judge who had common sense and a brain, and you said, here's the policy, here's the documentation, and they would go, okay. Like, we don't understand why you've been fighting for 5 years to get paid. So suffice it to say, there's a lot of audits. There are audit reviews that come out. If you read the CMS, updates that come out, you can see they'll do a slew of audits, and then they'll report back all the things that they found and how much money they took back. But where's the number that I love? Improper payments to the DME industry, which is us under this, $2.19 billion that they took back. So I know it's hard. I've been in the shoes of people in the field when they're yelling and screaming at you or whatever, because the customer's yelling and screaming at you, like, why do I have to do this? It's Friday afternoon. Joe Blow Home Care Company doesn't make me do this. La 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 la. That's why, because they took back $2.19 billion. When you've provided care for people and your team has worked really, really hard to keep them out of the hospital, get them, it's National Nutrition Month for a few more days still. We've been doing highlights every week of a patient, like a success story, like Parenteral Nutrition. We had one last week that it was a girl who was, 88 pounds or something like that when she started with us. Took 3 years, she's up to 125, and we had her before and after pictures. And even though we deal with this all day long, and we have for years as dietitians, pharmacists, like people were like, oh my God, I'm crying looking at this. Like, you deserve to get paid for doing that. Don't give the money back if you don't have to. None of us wants to do that. So we need all the pieces of paper. Reduce the amount paid, So just be cognizant. We're NHIA, and I will give a little bit of a two-center. We're monitoring, right, Bill? Some of us sit on committees with the jurisdiction A, B, C, D. If you guys see things like a new trend, like, hey, we never got audited on this much, or is this new, like, hey, there's no more DIFs, is that causing more trouble than it's worth 9 months from now? That's the kind of information that we need so that we can go back to CMS and the DME Max and say, hey, you said this was going to reduce administrative burden, but here's some of the trends that we're seeing. We are getting audited more. So if you have questions on that, Bill's in the back of the room. But I think this is a cause for a little bit of concern in our industry that as of January 1, the DIFs just went away. The way the government explains it is you should have everything in your medical chart that was written on those DIFs anyway. And that's what they're saying. Oh, we're going to help you eliminate this one piece of paper, because if you have all the clinical docs that you need, the supporting documentation, the ABN, the SWO, the proof of delivery, whatever, it should all be in your records. And if we ask you for it, you should be able to produce it. So that's where they're coming from, but know that we're keeping an eye on that. Jacqueline, you want to take over?
Sure. On the screen here, this is kind of just a slide for your reference, but the latest or the current PN LCD link is on this slide, as well as the latest or current Enteral Nutrition LCD. So those are links directly to the LCDs, and then within each LCD on cms.gov, there are links then for the policy articles and any other supporting documentation that CMS references in the actual LCD. So, all right, our National Home Infusion company looked back at some Medicare referrals and specifically the Medicare PN patients who qualified or met coverage criteria. So we went back to 2019, and back in 2019, patients needed to meet the original coverage criteria. And then in 2022, of course, patients were meeting the current or most updated coverage criteria. So really comparing those patients who qualified in 2019 versus those patients who qualified for home PN coverage in 2022. So this is parenteral nutrition specifically. I should really make sure I point that out. And in 2022, what we saw is that 46% of Medicare patients were qualifying, or 46% of those Medicare referrals were meeting the latest coverage criteria. But when we looked at 2019 versus 2022 specifically, back in 2019, there were only 5 diagnoses that were really meeting coverage criteria. So the original Medicare coverage criteria for home PN really specified a diagnosis that the patient had to have. And although there were, I wrote them all down, 8 diagnoses listed on the original coverage criteria, in 2019, out of those patients who qualified with our National Home Infusion Company, we only were seeing 5 of those diagnoses. And they included a Crohn's disease exacerbation, enterocutaneous fistula, malabsorption, small bowel obstruction, and short bowel syndrome. And so that's indicated on the slide by the blue color, if you're able to see that. And then in 2022, we saw 12 diagnoses actually meeting coverage criteria. So that's a huge increase, going from, patients had to have one of 8, diagnoses listed on the original coverage criteria, and we only saw 5 of those really meeting coverage criteria, within the population we were looking at. And then in 2022 to go up to see 12 diagnoses actually meeting coverage criteria is really great. And that just kind of speaks to the increase in Medicare beneficiaries meeting coverage criteria. And interestingly, with the original coverage criteria, we didn't really see many patients with oncology-related diagnoses meeting that criteria. And that was kind of a big miss, or a missed population. There were many oncology patients who needed home PN, but if they were a Medicare beneficiary, in most cases, they just didn't meet the coverage criteria. So out of the 12 diagnoses that we saw meeting criteria in 2022, there were 2 that really kind of shot up, and of course you can see them on the slide here, but specifically small bowel obstruction. So the original Medicare criteria for a bowel obstruction or small bowel obstruction was pretty strict, and with the updates to the LCD, we no longer had to prove it with a test or with some kind of imaging that the patient had a complete mechanical small bowel obstruction. And so that became a really big increase. We went from 7% of patients in 2019 having a small bowel obstruction to 34% in 2022. And then the other big increase was seen with malabsorption. And in 2019, 7% of our qualifying patients had malabsorption, and in 2022, 15% had malabsorption. So those were really the 2 diagnoses that increased the most from 2019 with the original criteria to 2022 with the latest criteria. And so when I talked about the list of qualifying diagnoses increasing from really 5 diagnoses, and this kind of look back to 12 diagnoses, that was a 140% increase. So 5 to 12 is a 140% increase. So that was really interesting to see. So Penny, we can go to the next slide.
Yep, let me just comment too. Think about it. In the old days, I used to say, almost nobody with cancer is going to meet the criteria. Nobody. If you had a partial small bowel obstruction, I think that's why you see the largest jump in the red colored line, is that now if you have a cancer patient or anybody with a small bowel obstruction and it's partial, you can qualify them. If the chart supports the notion that they can't absorb nutrients and it's spelled out, and before that, nobody would qualify because you had to do a tube feeding trial, and that was almost near to impossible to do. You wouldn't do that. So significant difference for patients that had cancer that never qualified. Now the potential is there, and we have that overlap of obstructions with an oncology diagnosis. Same thing with the malabsorption. The fecal fat tripped you up every time, right? God, we've been fighting to ask for the fecal fat to be thrown out the window for over 20 years, and they didn't listen. Now you don't need a fecal fat to prove malabsorption, and that's why we can qualify more patients. That's so 1970s, old school. It still might be done, but it is pretty rare. So again, that's where when we talk about access and things opening up a little bit, that's where we really saw the biggest difference, which is why that access went up to 5 out of 10 patients instead of 1 out of 10 patients.
We can skip this slide because I kind of already gave these numbers.
There we go.
But that was a perfect segue to this slide.
Yep.
We're, as Penny said, if a patient had an oncology diagnosis with the original coverage criteria, they almost never really met that criteria for home PN coverage, and that's really the biggest difference that we're seeing with the updated LCD. So out of those patients who qualified because they had a primary diagnosis of small bowel obstruction, 93% of them also had an oncology-related diagnosis. 93%. So, Penny really explained why in the past those partial small bowel obstructions most of the time or very frequently weren't meeting coverage criteria, and so many of those patients likely had an oncology diagnosis, because that's really the biggest and most impactful increase that we've seen with the updated LCD. And then of those patients who qualified because they had a primary PN-related diagnosis of malabsorption, 31% of those patients also had an oncology-related diagnosis. So, when we are thinking about what patient population has really been impacted the most by the updates to the parenteral nutrition LCD, I would go on and say that that's patients with oncology. And so that cancer diagnosis typically is not going to meet even the updated coverage criteria. But if they have a primary diagnosis impacting the GI tract and they also have an oncology diagnosis, that's really where we're seeing the biggest changes. All right, so what are our options when a patient doesn't meet even, the updated coverage criteria? Really, the options are still the same as they've always been, even though we are seeing more patients getting coverage, more Medicare beneficiaries getting coverage for the home PN that they need. There still are some patients, actually 54% of patients still are not meeting that coverage criteria. And most often that comes down to the length of need. If that patient only needs home parenteral nutrition short-term for a couple of weeks until they can go back in for a surgery or whatever the case is, then they're just unfortunately not going to meet the Medicare coverage criteria. So what are their options? They could be discharged home without parenteral nutrition. So if that patient can get by, or if the PN was just supplemental in the hospital, to where discharging home without it is an option, well, that's one of your options. Or referral to a facility. So if a patient is either in the hospital or like a long-term care facility, then, and they're a Medicare beneficiary, of course, then their Medicare Part A covers their PN, whereas when they go home on PN, then that's covered under Medicare Part B. So Medicare Part A does not have the coverage criteria for PN that Medicare Part B does. So another option is for that patient to go to a facility. So that's frequently what we're seeing is if the patient only needs parenteral nutrition, again for 4 weeks until they can come back and get surgery, then going to a facility for that time is an option. And then staying in the hospital, not a great option, but it's an option. So if they do still need PN and going to a facility just isn't, a good option for that patient, and they don't meet coverage criteria to go home on PN, then staying in the hospital is technically an option. But nobody wants to stay in the hospital just for parenteral nutrition, and really that's not an indication to stay in the hospital. But it is up there as an option. And then a hospital letter of agreement, that's really where, like if a hospital says, well, the patient's payment days are up, so we're not getting paid for the patient staying in the hospital anymore. So if we keep them here just for them to be on PN, we're not going to get paid. It's actually cheaper for us for the patient to go home. Then the hospital might sign an agreement with a home infusion company and pay for that PN that the patient's going to get at home. And then self-pay. I always kind of cringe a little bit saying that option because I realize it's not a great choice for most of our patients, but it is an option, and all options should be offered to patients if they're not meeting that coverage criteria. If a home infusion company is going to bill either the patient, they're going to send that patient a bill for a self-pay PN, or if the patient doesn't meet Medicare coverage criteria, but they have a secondary insurance that will pay for that PN, then an ABN does have to be signed and on file with that home infusion company, technically prior to start of care. So before you can bill that secondary insurance, or before you can send the patient a bill for self-pay PN, you have to have a signed ABN on file, and that's something that I know can frequently get missed. We heard that sometimes in the, or a couple of times, in the roundtable last night also. So having that ABN is really important and does have to be signed and on file prior to start of care before you can start billing anybody else for that PN.
All right, so call to action, and we're wrapping it up right now really with the summary. As we've said, we've still got about half of the Medicare PN referrals out there where people are not meeting the criteria, so therefore don't have access, even though they've paid into the system their whole life. So what do we do about that? And again, I think you've heard it repeated over and over again. Anything that you can do, like there's going to be new calls to action coming out for when we resurrect, the bills. We're in the 118th Congress now, so it may be that you go, well, I'm not comfortable calling my state senator. I'm not comfortable calling my, representative. But you can do a form letter, you can click when we make it easy for you and send something out. You can send a story of a patient. You can send a story if there's someone in your family, like the previous Erica, you know, she said she was a hyperemesis patient. It's not Medicare, but, you know, all of us probably, unfortunately, know someone in our family, in our life, in our circle of friends that has had cancer, that has suffered, that may or may not have had benefits to cover the therapy that they need. So speaking up will help. It takes all of us. You know, we've all said none of us started out by being advocates or knowing what we're supposed to do. So what do we do moving forward? You know, and I know this is controversial for some of you. I get feedback every year like, Penny, you can't say that we're going to take it out of the DME benefit. You know, the thing is we have to think outside of the box, you know, and it may not happen in our lifetime, but if you've paid into the system your whole life, and it's a benefit, and it's a life-saving benefit, and you need parenteral nutrition, I'm sorry, you should have access to it. So either we continue to fight for a legitimate home infusion benefit for Medicare beneficiaries, like all the other payers we have, not that those are all perfect either, but we need coverage so that you have access to home IV antibiotics or whatever therapy that you need. So right now, you know, we're in the DME benefit for PN and EN. What does that look like? Does Part D, you know, fit better? Does another, you know, something else out of the box fit better? I don't know, but I still think, you know, we need to fight to have a better job, to have patients be able to have access to the therapies that they need and have it be paid for. So, you know, it's going to take a village. It's going to take all of us. Does it go under the external infusion pump benefit? I don't know, but I think that more work has to be done, and, you know, it's just the right thing to do. So every couple years, unfortunately, we're starting all anew with the new Congress. So, you know, we resurrect our efforts, and that's NHIA is your voice. We're all in it together, and it really takes collaboration. We would have never gotten the changes to this had Aspen and OLI and NHIA not worked together. And they have for years and years, and it took partnering again, Aspen Public Policy, Bill and I getting together, pulling people that we knew in the industry, like, all right, you know, like I said, let's give it another go. Let's go talk. Maybe there's some new blood. I mean, that's honestly what happened. There was some new medical directors. In the past, some of them didn't listen, never listened. I remember talking to the Region A guy multiple times over the years, and he'd be like, Penny, what people don't understand is this is not a nutrition benefit. That was what he would say. And we'd get the letters back saying, denied, our policy's the gold standard, you know. So we can't accept this as the gold standard. This is not the gold standard when half of the people don't have coverage. So I digress, but if I can empower you to step out of your comfort zone a little bit, when your doctor or case manager is yelling at you and saying, who do I call? You know, whatever. Well, you can call your state senator or your congressman. I mean, we've said that for years, that this is, people forget it's a federal policy, you know. Oh, do we have? Okay. Oh, I wish I had my other one. I don't have the stuff about fraud and abuse in this one. Okay. Oh, all right, yeah. Okay, yeah, it goes through it in the fall 2022, it gives an overview of that. I'm mixing up my decks. But here, if your customer says, well, that's just your company's policy, or why does your company do this and nobody else does, there's plenty of objective resources out there where you can point them in the right direction and say, no, this is in NHIA's magazine, it's in Practical Gastroenterology, this is well known, or if you like, I can even send you the actual policy article in LCD. I've done that before because they just don't understand, you know, and you don't want them to, I say, I don't want you to have to read this, but just so you see, I'm not making this up, it's on cms.gov. But if you feel like you want a refresher, you want a review for your team, your billers, to understand the history, what's going on, we do add, on the fall 2022 one, talk about, you know, be careful. It's easy when things are gray for people to say, all right, go back and tell the doctor this is the policy and this is what it is, and then they go back and they never document what you ask them to document. You say, well, if they really said that, can you write that in a narrative for me in the progress notes, if that's what you're saying, and then it comes back and it's something totally different right before discharge. That can be construed as fraudulent. You know, if you think about what False Claims Act, a lot of times people will say, well, can't you just bill it? just bill it and put it through and see what happens. It doesn't work that way with Medicare. Our job as providers is to determine qualification for coverage prior to the start of care. Do you have what you need or not? Prior to the start of care. If you say, yep, I do, I know we have everything, good to go, then you bill it. If you bill it by mistake or you make mistakes in billing, if you read the language of False Claims Act, it's not just intentional. It's if you bill, Medicare, Medicaid, even, you were well-intentioned, but you made a lot of mistakes, or you billed somebody that doesn't have coverage, that can be construed as False Claims Act. And it's a felony, and there's high fines and all of that. Anti-kickback, I think all of us who work for any kind of company, you might have a once-a-year thing you got to listen to and, click off and attest that you read it. When I started in home infusion, that was in the early days of the early 90s when the first settlements took place. There was a company outside of Boston that settled with the federal government. Jeannie will remember, for $700 million. And it was putting people on TPN and writing things that, whatever. And it was potentially anti-kickback. So we got grilled on that stuff by our lawyers all the time, not a once a year. Those things are still in place and they're serious. It's a lot of money. Fraud and abuse brings a lot of money into the federal government. So keep that in mind. You don't want to be, because you say, I'm going to give you a nurse. And it's not just money. It's, people forget it's in cash or kind, it's in the article. But in the old days, it was oh, they got a fax machine from XYZ company, or they gave them a liaison nurse for free, or they let the dietitian talk to all their patients. That can be construed as a kickback. You're giving somebody something for free in exchange for business. So just be careful with that. I think the onus is on all of us. We haven't seen that much of that in recent years, but it's still out there. Some of the biggest cases have been with IDPN, so I know that's a hot topic sometimes that comes up. Interdialytic PN, parenteral nutrition, it's not total parenteral nutrition. People say, can patients qualify under that? If they meet the criteria we just talked about, sure. But if you're just hanging a bag of amino acid to get their albumin level up, no, they don't meet the criteria. So there's nuances like that. So I'll stop talking. Let's open it up for a couple of questions anyway. I apologize. Anybody have any questions about anything related to parenteral enteral? Why don't you come up and Jacqueline can give you the mic so we can hear you. Oh, there's a mic right there. You're good.
So has NHIA worked with the DMACs about doing prior authorizations on TPN rather than retro audits on them?
Bill? Not to my knowledge. I mean, this was a change, and it used to be in the old days, you submitted your chart, you submitted everything, you got denied or you didn't, whatever, and it's, pardon my language, it's an ass-backward way to do it, right? Hey, I'm gonna bill for a year, yay, and then I get audited, and it's oh, I didn't have what I need. Oh, all right, I gotta give the money back now.
So the prior auths are fairly new for CMS. They don't have the wherewithal to process prior auths in a large capacity. They've used it for power mobility devices, and they've just expanded it a little more. We've had that conversation, but I've talked to some that don't want it because that PA process doesn't happen fast enough to get a patient out. And if you take that patient home, but there's a prior auth process, there may be more risk than there is now. So maybe eventually it gets there and there's some automated process that would work, but that's what I have to say. We brought it up. We know it's there for PMD. As being on those councils, we kind of follow what that process is. And if we thought it was beneficial, we'd certainly jump, but I'm not sure it is right now.
It might be another whole big bottleneck, right? Then you're sitting and waiting for a prior auth for how long? We waited for hearings for 3 years, 5 years. It's way better now, but there's that part too. Anybody else? Way back? get the service going. Yep. Yeah, he's asking about ABNs, and, when you, yeah, that's why it's hard to hear. ABNs, he said, do you have to get it signed and on file before you get the therapy going or before you bill? So the answer to that piece was prior to the start of care, you need that on file, because you can't bill for those days. Let's say you get it next week, but you started today, you don't start billing till next week when you have that on file. And the ABN is really, you're telling the beneficiary, you don't have coverage, here's the reason why, and you're gonna be responsible. So they're acknowledging, like, you know what, so anytime you're gonna try, Medicare doesn't cover, you've got another payer source, whether it's a secondary, the patient, the hospital, anybody you're gonna collect money from, then you need an ABN, for sure. And you were saying like an antibiotic or something, are you talking about when you put it through a pump, whatever, so it's technically under the external infusion pump benefit, right? So Bill, you can confirm. He'd have to talk to the MAC to confirm. Oh, he was asked that same question an hour ago. Yeah. Yeah. He's going to confirm that. We'll put it out on the NHIA website. Yeah, the ABN thing is a bugaboo, and it just comes up for 30 years. The questions about ABNs come up over and over and over again. It is confusing.
Just to comment on the prior auth part, I do think Cover My Meds has made everything a little more nimble, if that would be a potential to run the TPN through that same type of prior auth, potentially. I don't know.
That's why we're always talking to the DME Max, seeing what we can do to get, we have an ear once a quarter, 4 times a year, to meet with them and bring things up. Way in the back. Yep, good question. We just went through this. Her question was about standard written orders. You get your standard written order. The start date is today, 3/28. You send it out to the doc. He signs it, and he signs on 4/3. Not good. You got to eat those days. What we did recently, and this is legitimately okay, on our order form, we've got the start date, start of care date, and down at the bottom, we have a physician's signature line. We took the date that was next to the signature away. So it is legal, it's for that date span, it's the start of care, the signature's there, because you're not gonna have a signed SWO prior to the start of care. You're just not. So that helped alleviate that problem. I can't hear you, I'm sorry. You don't lose anything, because what you're billing from is that start of care date or the date of that PN order, that date span. He signed it, you just didn't get it back. You can drop the bill once you... If he dated it, you're SOL. If he dated it, then you start billing on the day that he dated it. We've had takebacks on that recently, and that's why I can say this topic has been a hot topic for us recently, where we've had exactly that scenario happen, and we're like, oh no. And we went round and round, with different departments and said, do we have to have that date next to his signature? And they're like, no. And we're like, take it off. So now we've got the dates of the script, the start date of the script, signatures at the bottom, we're good to go. But if he already dated it, you bill for the days moving forward.
It's not a change, it's kind of a gray area. And we just, what Penny is
We
speaking
learned
from
it
is-
by a lot of takebacks.
Yeah.
Right.
That's what it said. That's what it says, it's like before submitting the claim.
We've had a number of issues on it lately because of that doctor signing it like a month later to get the SWO back. And yeah, it's...
Yeah.
Yeah, we could go. At 4:30, we have a roundtable if you want to keep asking questions. That's a great idea. So thank you so much. Oh, yes, sorry. Oh, QR code, right? There you go. Sorry.